I'm Dr. Roberta Keller. I work at the University of California, San Francisco, the Benioff Children's Hospital. And my specialty is neonatology, which is newborn intensive care. And my area of focus is newborn lung disease and pulmonary vascular disease and lung disease leading to chronic problems with pulmonary hypertension. Neonatology is newborn intensive care, and so we take care of babies who are sick from birth. So many times that means babies who are born preterm, so they need intensive care from the time of birth due to their small size and underdeveloped lungs and organ systems. So to help support their breathing, their gas exchange, but also to help feed them safely and get them nourished and growing and get them to the point that they can come off of that support. In addition, there's a large population of babies we take care of who are born with birth defects that require, again, intensive care. And the ones that I focus on are ones that affect the development of the lungs. So a baby with diaphragmatic hernia who's born at term, on time, can have the size of lungs of a baby who weighs 1,000 grams, which is 2 pounds. So even though they're born at a normal size, they have these very tiny lungs that are underdeveloped. They don't function well. They don't exchange gas well. And on top of that, the pulmonary vascular bed is underdeveloped, causes circulatory compromise along with the impaired gas exchange. So the things that we focus on, again, are these children who are born very early, but also children who are born with birth defects who require supportive care in order to get to the point that they can breathe on their own, eat on their own, and get adequately nourished. So what we see normally when babies are born healthy with normally developed lungs is that they have, when they're in utero inside the mother, they have a relatively high pulmonary vascular resistance. So their blood vessels in their lungs are developed normally, but they're somewhat constricted and the normal fetal circulation because blood flow to the lungs is decreased compared to what it needs to be once you're exchanging gas through your lungs. So the lungs are a growing organ, but they're not functioning for gas exchange. The placenta does that. So you exchange gas from your mother, and that's how the fetus gets oxygenated and is able to clear its carbon dioxide. So what happens at birth when a healthy baby first cries and takes that big breath that everyone likes to hear and gets excited about is their lungs open up, and as the oxygen comes in, so they've been in a very low oxygen environment, now they're breathing room air, but that's already more oxygen than they were exposed to. As the oxygen comes in and the lungs open up, those blood vessels relax and dilate, and a bunch more blood flow starts going through the lungs. And within 24 hours, you have the same amount of blood flow going through the lungs that you have going to the body. Babies who are born with birth defects that affect their lung development, the blood vessels to the lung, there's fewer of them, so it's a smaller vascular bed. So when they get that relaxation, there's just not as much area for the blood to travel through. And then sometimes also those blood vessels don't relax in the usual way. And so they don't go through that normal transition in the first 24 hours, in fact, have a very delayed transition. So many of them are born with pulmonary hypertension. Now, what we've shown in some of the work we've done with congenital diaphragmatic hernia by following these very sick babies with serial echocardiograms is most of the babies who do well actually transition, at least by echocardiogram, around between 2 and 3 weeks of age, somewhere in that range. So as opposed to the first 2 to 3 days of age, their transition is delayed to 2 to 3 weeks of age. So those children who do well are still able to transition. It's just a very delayed transition. And during that period of time, they have some degree of pulmonary hypertension. Then there's a proportion of kids who don't transition, right? So they get out to that 2 to 3 weeks of age and they still have quite significant pulmonary hypertension. And those are the children, I think, that we really need to focus on. And some of the recommendations we had in the guidelines are focused on that group of kids. So some of the recommendations in the guidelines are focused on not doing harmful things. So yes, we know they have pulmonary hypertension, but we also know they have small lungs that are vulnerable to injury. And so let's be judicious in the support we give. Let's give them enough support, but maybe calibrate our expectations as to what enough support is, and really try and not harm things and allow that transition to happen, even though it's going to be delayed to 2 to 3 weeks of age instead of by 2 to 3 days of age. So some of the recommendations and the guidelines are really focused on that. Let's allow that to happen, and by not harming things and causing that to be delayed and causing more problems. But then some of the other recommendations are focused around, well, then what happens when you don't make that transition? And those children who really have much more problems with persistence of pulmonary hypertension and maybe even some changes in their pulmonary vasculature, that they're starting to really have more pulmonary vascular disease. And so the recommendations we've made there are, one is try and preserve right heart function. So the right heart is the dominant ventricle in utero. So it knows how to work by allowing it to not have to pump always against the pulmonary circulation, if that is a very constricted small vascular bed, by keeping the ductus arteriosus, which is a normal vessel inside the uterus in fetal life, by allowing that to stay open, allowing the right ventricle to have that and sort of maintain that fetal circulation, we can protect to some extent the right heart function while we're allowing for that delayed transition in those babies who take longer than 2 to 3 weeks. And then for those kids who really fail to even, transition by 4 to 6 weeks of age, thinking about evaluating them in the same way we evaluate any children who we're concerned about chronic pulmonary hypertension, and really, making sure we get the information we need to think about the types of treatments they might need long term.